I'm Dr. Alabi BF. I'm an ACLS and BLS instructor, and today I'm going to be taking a course on cardiopulmonary resuscitation, and more effectively we are going to capture it under the chain of survival and the system of care. Thank you. Okay, now how do people die? Basically, there are three signs of life, and people lose them one after the other in the dying process. It's good for us to understand this so that we know the focus of cardiopulmonary resuscitation. The signs of life are: number one, consciousness; number two, breathing; number three, pulse or palpable pulse. Okay, now when people want to die, they lose all these three signs of life, and that is why there are three major signs we want you to look for. So if you have a patient that is not responsive, that means unconscious; that is not breathing, that means the patient is apneic; and that does not have a palpable central pulse, we know that the patient is dead clinically, but it's potentially reversible, and it is the chance for the patient to come back that you want to give the patient during your CPR. Okay, now the second foundation that we must lay is the fact that irrespective of the primary cause of death, every dying patient in their final descent into immortality, they will pass through a junction of cardiopulmonary arrest, where effective CPR can make the difference between life and death, where effective life support, basic or advanced life support, can make the difference between life and death. What we mean is, for example, if somebody has sudden cardiac arrest and is dying because of that, if somebody has maybe shock, or somebody has trauma, or somebody is having complication of a chronic medical condition that eventually want to lead to death, we will say the person is dead only when the heart has stopped to function and the lungs have come to function. So that is cardiopulmonary arrest. Now at that junction, your CPR can make the difference between life and death. Now, it's not enough for you as a professional, healthcare professional, to have the soft skill of CPR. For your CPR to be effective and to produce the expected outcome, you must locate your practice within a larger system of care. And metaphorically, American Heart Association and the Resuscitation Council of Southern Africa have captured this under what they call the chain of survival. So briefly, let's review the links in this chain of survival. There used to be 4 links in the chain of survival, but the current guideline has added the 5th one. So we're going to discuss them. The first link in the chain of survival is early recognition of an impending arrest and early activation of the EMS system. EMS means emergency medical service system. So what we mean is this: if somebody is going to have cardiac arrest, and the cardiac arrest is going to result from heart attack, which is the most frequent cause of cardiac arrest, now it's going to be having pain, which if people around can quickly sense, they have a chance, they have the opportunity of picking that up and then calling an emergency response number. So that is where it begins. So that means people should understand the kind of chest pain that may be cardiac in origin. Briefly, let's describe it as the pain at the center of the chest that is deep seated. Many people will describe it as they feel like an elephant sitting on their chest, and then it can radiate to the shoulder, to the arms, to the back, and the patient may have a sense of doom. They may be sweating and may feel very uncomfortable. Now, if you have anybody feeling like that around you, suspect heart attack, which we medically call myocardial infarction. Now, if at that point you can call an emergency response line, then you have fulfilled the first link in the chain of survival. The second link in the chain of survival is early defibrillation. Okay? Now, early defibrillation means that there must be an AED that is very close to the patient, so that while you are waiting for an ambulance to come, for example, if it occurs in a pre-hospital setting and the patient goes into an arrest, then you should be able to deliver shock as soon as possible, because the chance of successful defibrillation or shock wanes with the passage of time. So a patient that is able to get shock in the first minute, for example, will do better than a patient that cannot get shock until several minutes have passed. Okay, so the third link in the chain of survival is early advanced life support, or early advanced cardiovascular life support. Now, there are some interventions that will contribute to saving the patient's life that cannot be performed until we have advanced care or advanced life support capable facility. So some of the ambulances in some other countries are equipped to provide advanced life support care, so they must come on time, and studies have also shown that advanced life support intervention can improve the patient chance of survival. And the fourth link, that's the fourth link. Now the fifth link that was just added recently is early post-resuscitation care. Now you've done everything and your patient has come back with a palpable pulse. So what is the next thing you want to do for this patient? Before now, many of the patients that have been successfully resuscitated to the level of having return of spontaneous circulation, they also died because there is no organized protocol. There is no organized system of intervention to take care of them after they've come back. So we lose many of them to complications of the cardiac arrest itself. So, but recently, the American Association has included a link that will help us to go in a systematic way to take care of that, and that is called the post-resuscitation care. And you can see this diagram has illustrated that the 5 links in the chain of survival for us and the way they interact. Now, what we are saying in essence is that if there is a society that has all the links in the chain of survival strengthened, then that society will enjoy the benefit of reducing the chance that a patient of sudden cardiac arrest will eventually die. And that means it presents an opportunity to save many of the people that will go into sudden cardiac arrest. Okay, now the next thing is the rapid response system, which is a system of care that should also be in place in a healthcare facility to be able to respond, that will enable them to respond to patients who may deteriorate acutely. A study shows that 87% of patients that have cardiac arrest inside the hospital have shown signs of physiological deterioration up to 8 hours before their actual arrest. Now that means that we have a chance to save them while they were deteriorating physiologically. But then, before we can do that effectively, we must be aware of that, number one. Number two, we must have set those physiological criteria and the intervention that should be carried out on patients that are manifesting them. And number three, we must also locate them within a protocol, and there must be a team of responder that can come on board on time. Now, these are some of the things. For example, if you have a patient with threatened airway, maybe with airway obstruction, how do you know that? A patient's breathing is supposed to be quiet and effortless, but you have a patient on the ward, for example, that suddenly starts breathing heavily or with sounds, snoring, sound during inspiration or expiration. That may be a sign that the airway is getting blocked or threatened. Now, respiratory rate. If the respiratory rate suddenly becomes very fast or very slow, that's also a red line, a red flag, and it's also one of the indications of deteriorating medical condition that may eventually lead to cardiac arrest. Or the heart rate is too slow, so all of a sudden, or too fast all of a sudden, or the systolic beat blood pressure suddenly becomes very low, becomes less than 90 millimeter mercury. That shows that many of the organs in the body cannot be perfused, and that is also an impending sign of cardiac arrest. Or the patient has symptomatic hypertension or seizure or significant fall in urine output. Now, these are some of the signs that you should watch out for, that should prompt response from a rapid response team that already has been in place. Okay, now I have a table here that is to show us how we can triage an unconscious patient into one of 3 possible groups. Now, when people become unconscious and they present in the hospital, as a healthcare provider, you must be able to prioritize your intervention, because at that point there are 20 things that come to your mind, but which of them is necessary to be done, and how do you want to do them? But they are very, very simple, especially if you know how to use a table like this to sort out your patients that are unconscious. So this table, what it has done is to divide an unconscious patient into 3 groups. Okay, now group 1, we can have an unconscious patient that is breathing and that has a palpable pulse. Group 2, we can have an unconscious patient that is not breathing but that still has a palpable pulse. And the 3rd group is an unconscious patient without breath and without a palpable pulse. So how do you intervene when you are seeing a patient like this? So if a patient is unconscious, that means he's not responsive. You tap his shoulder and you shout out his name. Sir, are you okay? Mr. John, can you hear me? And you cannot find any response. Then check for breathing. If the patient is breathing, then that means this patient still has a palpable pulse, so you can quickly check that. For such patients, the immediate life support demand on them is to prevent them from choking on their own tongue. So you're going to mind the way this patient is being positioned. For example, if you're in a pre-hospital setting or you need to transport this patient from one facility to another, don't let this patient lie on his back, because it is commonly said that an unconscious patient lying on his back with his face gazing into heaven will soon be there to see things for himself. What will simply happen is that the tongue will fall back to obstruct the posterior wall of the hypopharynx, and that will block the airway, and that will be the end of that patient. So your life support intervention, before you ask for the cause of his unconsciousness, is to position him well on the side. Put him in left lateral position or right lateral position. We call it recovery position generally, and that will help the patient. Now, if you are in a facility where you may have access to basic airway equipment like oropharyngeal airway, nasopharyngeal airway, you can put it. Then in that situation, you can afford your patient lying on his back, because the airway will actually prevent the tongue from resting against the posterior wall of the hypopharynx. Now, when you've done that, then you can troubleshoot for the reversible cause of his unconsciousness and try to correct that and bring the patient out. For the second group of patients who are unconscious on one hand, in addition to that, they're also apneic. That means they're not breathing again. Now, that is medically what we call respiratory arrest. Not cardiac arrest yet, but respiratory arrest. Your requirement or your mandate as an emergency responder for such a patient is to give them positive pressure ventilation. That means you're going to take over the breathing of the patient. There are many things that can cause respiratory arrest, but in the immediate time you are seeing the patient, that is not your priority. The cause of the respiratory arrest is not your priority. What you want to do is to manage the patient and take over the breathing from the patient. So there are equipment you can use to do that. If you are alone, you can use a pocket mask and breathe through a pocket mask. If you don't have a pocket mask, you can do mouth-to-mouth breathing. If you have a pocket mask, breathe through it. Both of them will give the same FiO2 to your patient, which is like 17%. Your exhale here has 17% oxygen, so that can sustain the patient in that form. But if you have access to a bag mask, then you can ventilate that patient. So how do you do that? You give rescue breathing at the rate of 1 breath every 5 to 6 seconds without chest compression. Okay, so summarily, we said that if a patient is unconscious and is apneic, the diagnosis is